Hello, I'm Rob Califf, head of clinical strategy and policy at Verily Life Sciences and Google Health. I'm sad to not be in Durham today. It would have been great to be back home with so many friends and colleagues that I've worked with over the years, but such is life in the pandemic. What I want to talk about today are the opportunities in a digital clinical world before and after the pandemic, thinking that I've done as we persevered through this very difficult time that we've all been living with, reflecting on what I was thinking before about the opportunities for machine learning and artificial intelligence, and how that thinking may or may not have changed over the past few months. The bottom line is shown on this slide. I believe that we need to redouble our efforts to automate what we can automate with proper supervision to enable people to do what they most need to do and focus on what matters to people and patients. This is a list of some of the changes that were well underway before the pandemic, all of which I believe have been accelerated by COVID-19 and our societal response to it. First, we need to improve access to basic fundamental knowledge. I won't go through all the details of how obvious this is, but I think we all know that we not only need to serve up information that people prefer to see, but also figure out how to get authoritative and correct information to them in their daily lives. Second is what I call home inversion. We need to center care and learning around people where they live and work. This is something we talked about a lot over the last decade, but this has been moved into high gear by the pandemic. Third, we need to enable the healthcare team. And I really do mean team by this. All too often we talk about doctors and physicians when really there's an entire team of people that need to optimize their functioning together. Fourth, there needs to be a heavy emphasis on data integration and curation. We have access to large streams of data coming in all the time, and I noticed that many of the talks at this session focus on the need to get the data in order so that we can make sense of it. And this needs to include not only traditional healthcare, but also the social and behavioral data that will enable people to help themselves and also enable clinicians to help people as much as possible. Then we need to couple predictions with outcomes. It's not just enough to make a prediction. We have to follow through and understand how to deliver the consequences of that prediction, how to make a plan and follow through it so that clinical outcomes are improved. And then finally, combining all this information, it's entirely possible that we can make a major change in the way that we deal with individuals, but also populations, if we can understand how to combine individual information and population information in a way that informs both clinical care and policy. So first, just a few preparatory slides that are not new, but I think have been reinforced by the pandemic. This one just makes the point that although technology is moving rapidly, the human condition is essentially unchanged, and people's ability to deal with technology and its implications doesn't move as fast as the technology itself. Secondly, I'm going to focus on the United States, although very similar things could be said about many other areas of the world. But I want to make the point that the trajectory that we've been on has been one in which those who have means, those with the highest incomes and the greatest education, are doing better and better, while those who are disadvantaged, either due to economics, education, or race and ethnicity, are doing worse. And if we look at life expectancy in the US as one example, as a function of geography, this is not news to anyone. There is a huge difference in life expectancy as a function of where someone lives. It's over a decade, and within individual cities, there are up to 15-year difference in life expectancy, for example, in Washington, D.C., depending on which subway stop one lives close to. Obviously, this is a multifactorial issue, but one that we need to understand as we move forward. But more importantly than just the static life expectancy is the trajectory that we're on. we're seeing that the differences are continuing to expand and move in the wrong direction. This was true before the pandemic, and I'll show a few slides about what's happening during the pandemic, which should be a cause for alarm for all of us. The United States is doing particularly poorly with regard to common chronic disease before the pandemic and with regard to COVID-19 during the pandemic. This is just a look at the trajectory that the U.S. was on before the pandemic, last place among economically well-off countries. This is true for men and for women, and is a trend that's been going on for a long time, with almost all other countries increasing their life expectancy and the U.S. seeing a decline in life expectancy. This slide, which is a bit tongue-in-cheek, is taking a commonly used slide about trajectory with regard to life expectancy and health expenditures in most of the high-income countries, and looking at this over time. You can see there's one country that diverges from the rest, the U.S. And the tongue-in-cheek part, which is only partly so, makes a point that the simple things have made the biggest difference. It's not the high technology that differs among these countries, it's the way it's used and the purpose that we have in mind. Are we developing the technology to advantage some people over others, or are we developing the technology to improve health outcomes for all? And this is something that we will need to come to grips with as we regather in the wake of the pandemic. Just a couple of slides about the pandemic. This one speaks for itself. There's no reason to go over the details, but let's just say that the U.S. has done spectacularly poorly with regard to suppression of the virus compared to other high-income countries. Now, I'm not here to argue the politics of this. It's more just to make the point that we need to bring the fragmentation that we have in our society together for a common purpose to improve health outcomes. This slide makes a point in a different way, looking at death as an outcome. The U.S. is certainly not looking good compared to other countries in terms of overall mortality. It is interesting, though, that case fatality rate, the mortality rate of those who become infected, looks pretty good in the United States, demonstrating our emphasis on the technological parts of healthcare as opposed to the common determinants that are rooted in behavior and social factors. And so if we look at a state like Massachusetts, which is most advanced probably among states in terms of access to healthcare, it's very similar across the United States. The pandemic is affecting people who are disadvantaged to begin with at a much larger rate than other people. So in this case, focusing on race and ethnicity, we see that despite the fact that Massachusetts is largely a majority Caucasian state, a very high proportion of cases, hospitalizations, and deaths are occurring in people of color and of ethnic backgrounds other than the predominant Caucasian background. And so I would put forth that as we think about opportunities for machine learning, artificial intelligence, and health and healthcare, we're at a fork in the road. Are we going to use digital technology to improve health for populations and individuals with the concept that the rising tide raises all ships? Or are we going to use digital technology to segment the population, to optimize finances in a balkanized fashion in a way that will continue to magnify the disparities that we're already observing and which are becoming more stark due to the pandemic? So I'm going to put forward a couple of concepts here for people to think about. I'm obviously not a machine learning, artificial intelligence practitioner, but I'm someone who has lived in the environment for a long time and works collaboratively with many people who are expert in this area. So these are some things that I believe we need to do as the field evolves. And it relates directly to my work at Verily and also at Google Health. First on my list is improving access to knowledge. As simple as this sounds, it's obvious that people go to a limited number of sources to gain knowledge. We have to improve access in a way that appeals to the individual and tailors the information to the comprehension and preferences of the person. All this needs to be done while elevating reliable and authoritative sources. This is a much more difficult job than I knew before I started as FDA commissioner. Simply getting across basic information to a population of 320 million people, or the almost 8 billion people that live in the world, is a tremendous challenge in an area where I think the application of the methods of machine learning can be tremendously helpful. An easy way to think about this is some of you are too young to remember the days when libraries looked like this. The expert knew how to navigate the library, use the card catalog to find the relevant journal or book, and make a Xerox copy of it to distribute to other people. Now people expect to the tune of tens of millions of results per second to get the information immediately in real time in a way that's appealing to that individual. And we have much work to do to understand better and better how to organize the information in a way that's optimal for the individual. And when it comes to health, one of the more difficult issues is getting information across which may not be exactly what that person wants to see, but may be critical to their well-being in the future. A big area that we all need to work on together. The second area is what I call home inversion. Not a new concept that we would move prevention and chronic care to the home, school, workplace, and neighborhood. Now it's in full-fledged because of the pandemic. People don't want to come to clinics or the hospital unless they have to. And so as we prepare for a clinic visit or conduct a clinic visit or educate people after a clinic visit, tremendous opportunity to integrate information, use machine learning to optimize the way that information is presented, and to help people take actions that are to their benefit. Almost all of this now is occurring currently in a digital environment, and I don't think these changes are likely to go away anytime in the near future. An example which occurred before the pandemic, but I think really typifies it, is the concept that many searches that are done on Google search are health related. And the way information is presented to a broad population, we would all agree is suboptimal. Right now we have knowledge panels which make easily interpretable information available to the general public. But a great hope would be that working with the health and healthcare community, we can get better at personalizing or segmenting the information so that people get the best information for them in the circumstance that they're in the right time. Depression is a great example that I think makes the case very strongly in a pilot project that's already been conducted. Over 300 million people have depression in the world. Half of them actually never get treatment, as best we can tell. The time from the onset of depression to treatment averages about 7 years. And treatment is effective. It's not curative because this is a chronic disease, but it does make a difference in people's outcomes. Obviously, this is a large issue in the Google environment because so many people are seeking information and remedy on the internet. So what was done was, when it appeared that people were searching on depression, was to put up a flag that said, would you like to take a survey? That survey is a PHQ-9, which is a medically qualified questionnaire about depression that puts people on a scale. You'll notice that item number 9 here is suicidality, essentially. When people check that box, they are referred to the National Suicide Hotline. These screeners, as we now think of them, are being developed for a set of common chronic diseases and work that's underway. And I think is a great place for machine learning to be used to understand better how to give people what they need when they are expressing a healthcare problem. But this also makes a point that there are many people who are suffering and their clinicians don't even know that it's happening. And so connecting the world of home and work and school with the clinic is a major part of what we need to do. And so this brings up the healthcare team. And there's a tremendous need to optimize the function of all the members of the healthcare team so they're operating at the top of their skill set. This includes not only doctors and nurses, but the many types of workers in the healthcare environment, including social services, and even areas that we don't commonly think about in healthcare, like the logistics of environmental services, optimizing the environment at home. Obviously, a huge area where optimization of functionality using machine learning could play a major role. One way to think about this is for the common chronic diseases. 80% of death and disability is due to a limited number. If you look at the top 20 in the epidemiologic studies that have been done, listed on this slide are some of these top 20. And it looks like they all have some common elements where the proper approach to segmenting the information and tailoring the information could focus on those common elements like sleep, med optimization, diet, exercise, and the common elements of mental wellness, and then could tailor the information for the specific disease that was in play. Because while med optimization and adherence is important across all these medical problems, the specifics, of course, need to be tailored to the individual condition. And of course, telemedicine is now here to stay. Before the pandemic, we were all talking about it and trying to figure out how to get it done in a very difficult reimbursement environment in the United States. If we just take the case of diabetes as an example, it's obvious that most people with diabetes are not living in places where there's ready access to an endocrinologist. And so using this stream of digital interaction that's going on to optimize the clinical decision-making, to do as much as possible outside of the time of the clinician, and then optimize the clinician's time to interact with a patient in a way that's most effective. This is tremendous work ahead, taking digital information and applying machine learning and artificial intelligence. One example that we've been working on that much has been written about is the case of diabetic retinopathy. If we look at the retina, it's obviously an entry into the brain and the vasculature. But I think everyone in the audience is familiar with the machine learning that's been done, which matches up well with what an ophthalmologist can do in a detailed exam in terms of both identifying and classifying diabetic retinopathy. The methods of machine learning have been published. This is a technology which is now ready to go into clinical practice, but the question is how to do it. There is at least one technology now commonly used on the market, but it's going to be a while until we figure out how to integrate this technology with clinical practice. And just to make the point, if we think about the eye exam as one part of the care of a person with diabetes, as a standalone technology, it's very difficult. This needs to be integrated into a disease management system in which the examination of the eye is only one part of a much larger effort. Understanding how to do this is major work that I hope the whole community will work on. Next is coupling predictions with actions, and I know a number of the talks here are focused on this issue, but it's not enough to make a prediction. The question is, what do you do about it? A major role for machine learning, I believe, is going to be to flag deviations from standards of care in the context of predictions, which then lead to activation of care pathways. And for procedures and digitization that's occurring with those procedures, the field can now be used to guide procedures and assist the team. This is very early work, but really exciting as a cardiologist for me to see in action. And I'll use one example from the work we've done at Verily with Johnson & Johnson in a joint venture called Verb Surgical. The idea here is that machine learning can be used to capture the operative field, and that as many operations are done around the world attacking the same problem, one can begin to help the surgeon proactively. For example, if a particular maneuver by the surgeon has been found to be unsuccessful um, in past procedures by surgeons around the world, the machine learning could be used to notify that surgeon that maybe he should think twice about this procedure. This is very early work, but really exciting for someone who spent a career involved with complex procedures. And of course, the more common elements of care pathways involving teams of clinicians interacting with a patient have been very troublesome because of the lack of a coordinated digital environment. And this is from the case worked out by Google Health, working with the VA and the NHS in the United Kingdom to deal with the issue of acute renal failure in patients in the hospital. And I won't go through all the details here, but the point here is that the prediction is a relatively straightforward part of this. Doing something with a prediction is really complicated, not only because we need to know what interventions are effective, but we also need to know which members of the team need to be activated when to do something about the prediction, and the outcomes related to the activities of that team need to be followed. And we're getting near the end here, but I want to emphasize the importance of ingestion and curation of data. And at least the way I think about this, as I've really had the privilege of working with amazing ML and AI people in the Google environment, is that we're going to begin to see research and practice merge into a continuum where discovery and learning is continuously happening. But it's not just about predictions. And in fact, I've seen many cases now where curation of data may not be all that relevant if the only goal is to optimize a prediction. But if we want to do something about that prediction, we have to know which patient it is and what can be modified in a care pathway. And so ultimately, no matter how we slice it, we need to really focus on making sense of these large streams of data that come in from the electronic health record and from the interactions of people with their social and psychological environments that lead to differences in health outcomes. Our work in this might be typified by the Baseline Project, which I've now been involved in for many years. Involves a collaboration with Duke and Stanford with a concept that we've mapped the world, so now let's map human health. And I believe that mapping human health is a little bit more complicated than identifying all the roads in the world and keeping up with them, but that's pretty complicated in and of itself. This is just a list of all the streams of data that we're working with in the Baseline Project with a large number of volunteers in a project which is growing by leaps and bounds as people sign up for Project Baseline in various communities that have been created. But it's fair to say that we're not anywhere near where we need to be to integrate all these streams of data, but progress is being made. And as the data get better and better, the application of the methods of machine learning will be quite fruitful in identifying pathways and types of information which fit together to better predict transitions in health outcomes, which is a major goal of this project. And then lastly, precision health. And there won't be time to go through the details of this, but in the sense of integrating massive amounts of information, it's time now to bring together these worlds that have been disparate, the world of individual healthcare and the world of public health. I believe the pandemic has really made this abundantly clear. We can't separate the two. The basic public health maneuvers of wearing masks and social distancing have an enormous impact on the health of individuals. But when someone gets sick with COVID, not only do they need to practice good public health practices, but very intensive, individualized clinical care is absolutely critical. And so as we think about this in a broad sense, it is really a significant data science issue. How do we balance better clinical outcomes while trying to achieve lower costs and improving the experience of patients and clinicians? This is the Quadruple Lane. As I've tried to paint this picture, we have a massive amount of input into the system, and the output is multivariate. We'd like to say that all these all go in the same direction as we make an intervention, and often they will, but understanding when the direction of the outcomes is different related to an intervention will be a major task for us as we try to reduce disparities. This is just a picture of how, at least I think about precision medicine. It has as much to do with patient preferences as it has to do with the biology and physiology noted at the bottom. But there is no way to get to the kind of decision support we need without automating much of it and then applying the proper human oversight of this automation, which again, I know is the topic of many talks in this meeting. But beyond individual precision medicine, we now have the concept of precision public health. And this is the idea that if we integrate the information in the right way, we don't have to just talk about individuals. We can talk about neighborhoods. We can talk about cities, counties, and states. Again, I believe this has really been brought to the forefront by the heterogeneity of the way different states and counties in the U.S. have dealt with the pandemic. And I believe we'd be much better if we had an integrated information system that enabled analysis of scientific data to guide our public health practice as opposed to political opinions. And so if we integrate the individual and the community, it's perfectly within our power now with adequate computation to look at the trade-offs that occur between optimizing for a single individual and optimizing for a population and finding the right middle ground. So I'll conclude there and say it's really been a privilege to talk with you all. I look forward to the outcome of the meeting, and I hope we make the right choices to take the left fork in the road as opposed to the right. But much of this will depend on how we take advantage of this massive computational capability and apply the methods that all of you are working on for the right purpose. Thank you.